So, welcome back to the Cardio How podcast. We have a very special topic today. We're going to be focusing on the cardiovascular team. We'd like to talk a little bit about using the CV team members to extend cardiac care, help improve outcomes, increase patient satisfaction as well. And I have the pleasure of introducing a couple of guests who are pretty well known, I think, to our Ohio listeners. They're both CV team members that have been involved in the Ohio ACC chapter quite a bit recently. First, I'd like to introduce from here in Columbus, Andrea Robinson, who's actually the current liaison for our Ohio chapter for the Cardiovascular Team Council. Andrea, welcome.
Thanks, Kenny. It's a pleasure to be here, and I am excited to talk about this opportunity with CV Team Liaison and Leadership.
Thank you. Yeah, welcome. And then I'd also like to introduce Kelly Barsh. Kelly's a PharmD, also here in Columbus at The Ohio State University. She's a clinical pharmacist and works very closely in the cardiovascular division there. And she is the chair-elect, incoming chair of our CV Team Council here in Ohio. Kelly, welcome.
Thanks, Kenny. Looking forward to our conversation.
Yeah, so maybe we can start, Andrea, with you. I really wanted to get you on because I know, of course, you have a background in electrophysiology. You've been working in EP for several years here in Columbus. I've had the good fortune to work closely with you here at Ohio Health. Quite a few years ago now, I think it's been several, that you and your colleagues proposed a walk-in clinic for atrial fibrillation. And I really want our members to learn a little bit more about how that clinic was visualized and conceived and how it's worked. Obviously, we're all clinicians on the front line and deal with atrial fibrillation on a daily basis, inpatient, outpatient, and all kinds of settings. But what was really the rationale that led to considering this type of clinic versus the traditional way we deliver cardiac care?
Sure. So I think it really was multifactorial. I think number one, our initial focus was really on trying to visualize how we could provide better access to patients with atrial fibrillation. As we know, with our aging and increasingly comorbid population, the number of patients diagnosed with AFib is far outpacing the broad band of cardiologists or specifically electrophysiologists. And, I think with the wealth of data coming out in the last 10 years on, earlier access to rhythm-based care, showing improvement in outcomes and better cost of care, we really need to find a way to get these patients plugged in at the right time to the right provider. I think secondarily to that, we've also recognized that AFib is a really complex disease, and it usually takes more than just a quick conversation to really dig in and educate the patient on all treatment options, talk about risk factor modification, and really get them engaged in their care. And so we wanted to be able to offer a clinical model that would maybe address some of those constraints. And third thing, I think, is as one of the advanced practice providers, we really wanted to increase our value to the electrophysiology team. And we saw that we could really help fill that gap, that using our advanced practice providers to really be the forefront of this clinical model, we could really sort of offload our physician counterparts to, see different types of patients or remain in the lab doing interventions. And we could really help take on, the forefront of treating patients with AFib.
So obviously we know these patients are everywhere, right? They're in the emergency room, they're in the hospital service, they come to our clinics for new referrals. Were you focusing on a specific subset of AF patients when you conceived of the clinic? And then how did that lead to the actual structure of the clinic that you've created?
Yeah, so initially ours and other folks across the country that have used this model focus on the patients coming in through the ER. It's really widely accepted that a lot of patients with low risk AFib are probably unnecessarily admitted to the hospital. just because truly there's no better place to offer them quick access to care. And so path of least resistance is to hospitalize them. What we found is that average length of stay is 2 to 4 days for these patients, really just to get some face-to-face time with an arrhythmia specialist, maybe some imaging and a cardioversion. So on the inpatient side, I think that's where we really saw the need when we saw a lot of these patients coming in, and we thought we could offer something just as good, if not much better, in an outpatient setting to be able to lower cost of care and increase patient satisfaction. So yes, initially we focused on the acute patients. So we started off with some emergency department protocols, helping those colleagues basically evaluate patients and determine if they're appropriate for outpatient care, really focusing on, what are their risk factors? Would they be able to be rate controlled in an acute fashion, anticoagulated? And then our approach would be to see them within 2 business days in our clinic. We also kind of rolled out that acute algorithm to even our own practice with cardiology and EP, and as well as primary care. So previously, patients may call their cardiologist or call their primary care and report an acute episode of AFib, or it's incidentally found, and they would be sent to the ER. With these acute protocols, patients would instead bypass the ER altogether and come directly to our clinic.
Yeah. So I think that's a pretty aggressive goal, to take patients who would have otherwise been admitted into the hospital and try to see them in a 24 to 48-hour basis. Have you been able to accomplish that turnaround that you intended? And maybe just talk a little bit about the logistics of the clinic in terms of where it's located and who staffs it, et cetera.
Yeah, so we have, and that's been a really big priority of ours. When we initially met with the emergency department providers, they let us know that they were a little bit hesitant to adopt this model of care. They had been burned in the past by a lot of people come to the ERs and say, follow this protocol, discharge our patients. And, that really there weren't good safety nets in place to see the patients acutely. So patients would bounce back to the ER. So we really made it our goal to ensure that, every patient referred would be seen within 2 business days if it's for an acute episode. That's a metric that we follow very closely. We're 5 years into this now. We look at that metric pretty much continuously. And if we're ever starting to fall above that line of 2 business days, we've been able to really quickly react, adjust our access, whether it's adding more appointment times or another clinician to be able to be seen up in clinic. The providers that we have in clinic, we use advanced practice providers. But really, as a team-based care model, we rely on our clinic nurses as well to help triage a lot of the patients over the phone, to help decide when they need to come in, and if they need to come in prepared for a cardioversion, they need to come in fasting with a driver in anticipation of that. The APPs then do the majority of the clinical visit, making decisions about rate versus rhythm control, anticoagulation strategies, and the imaging or testing needed. And we're always collaborating with our physicians, so they're not necessarily coming up and meeting these patients face to face. But the big part of the goal of our clinic is not to have these patients followed longitudinally by our clinic. So if they're coming in for the first time, either with a new episode of AFib or just someone referred later on in their diagnosis, but they've never seen a cardiology clinician, or then sort of making the decision, should they or do they need to be established with EP? And if so, they'll then see them several weeks after follow-up. Some of these folks may be more appropriate to follow with clinical cardiology, and some are even okay to follow with their primary care. So, we do make sure everyone's tucked into someone for follow-up in the most appropriate fashion for them.
Yeah. So obviously, having referred many patients there, I can vouch for the increase in efficiency and help that you give all of our general cardiologists and other referring providers. I know, obviously, I assume most patients you're starting with maybe their antiarrhythmics or maybe just even an initial cardioversion with imaging. Are there some patients though that you would consider taking straight to more invasive treatments like potentially ablation and other things, or is it more of a stepwise kind of approach?
I mean, it's, increasingly there's been more data coming out showing early rhythm control, whether it's with an antiarrhythmic drug or catheter ablation in certain patients is superior to rate control. And other literature even suggests that, catheter ablation can be more beneficial than an antiarrhythmic drug in a subset of population of patients. So we really look at everyone individually, and I think one thing that makes our clinic work is we do follow kind of standardized protocols, but we're still looking at every patient and the characteristics about them pretty uniquely. It's also a shared decision-making interaction with every clinic visit. And I think that's part of what the biggest benefit to this atrial fibrillation clinic model is that, previously we would see patients, referred pretty late in their diagnosis. And, they may be persistent AFib or longstanding persistent. They'd be referred to EP and they maybe have never even heard that ablation is an option for them. And so we're really working to try and see these patients early on in the diagnosis and really just start with really good education about all treatment options and really helping them understand the difference between rate and rhythm control and the risks and benefits of choosing each strategy. And from there, patients have the knowledge to sort of, take a larger role in their decision making and participate in their care and help make those decisions too.
Yeah, and you mentioned education. I think, one thing we see when patients are admitted with an acute episode of AF, there's not often a lot of time to address a lot of the comorbidity and contributing factors. And of course, we all know that AF tends to cluster with so many other conditions, hypertension, sleep apnea, in a sedentary lifestyle, et cetera. Do you try to address some of those things as well with the patients, since you're in a little bit a different scenario than, say, when we're doing an inpatient consultation?
Yeah, absolutely. And so that's something else that we've sort of hardwired into every visit. So, it's a hospital-based clinic. We sort of pulled it out from our general clinical setting so we could really design our appointment slots based off of what the need of the patient was, not necessarily just trying to fill a template. So we have 50-minute visits to really allow for that education. So everyone gets a good conversation. They fill out their own CHATS fast score. We talk about anticoagulation. We talk about rate and rhythm control, but then we do carve out time each visit to make sure we go through and we identify all of the risk factors for atrial fibrillation. We calculate their BMIs. We look at whether their blood pressure is at goal. We screen for sleep apnea. We talk about alcohol. And then based off of the findings, we then help come up with an individual plan on whether they need to be referred for a sleep study. We'll involve their, primary care if we need further assistance with getting their cholesterol or their blood pressure to goal. And then we actually we follow up with our patients as well pretty well. So, we have certain metrics when we want to refer patients to weight management or sleep management. And then that's where the nurses really come in. We know that that's sort of a sensitive topic to talk about with patients. And so our nurses do a really good job of doing a follow-up call several weeks later to really ask and say, hey, the referral was put in for sleep or weight. Have you been able to think about it? Did you make the decision to go ahead and proceed and, sign up for a weight loss program? And I think that's what, it's also a nice benefit of our clinic is that it's a smaller cohort than we follow. So, our nurses and our APPs are really engaged with this population. The patients feel very safe to talk about these things. And so I think that's where we've really been able to see some success in getting patients closer to their goals for risk factor modification.
Yeah, well, thanks. You and the rest of your team deserve to be commended for, creating a new program that didn't exist and meeting a need. What are some of the future goals, for the clinic? And are there still some challenges you're trying to overcome as you try to grow this and care for this growing, patient population?
Yeah, I mean, so it's always been evolving. As I mentioned, it really was in the beginning focused on the acute patients and keeping them out of the hospital and the ER. And then it slowly evolved to now we also have a really big focus on trying to get patients in after their first diagnosis of AFib, sort of becoming like the front door to our EP practice. And that's going to require, if we're going to continue to fulfill that with this growing population, it's going to require, probably expanding the clinic a little bit to be able to meet the needs as that population is growing. We also want to be able to offer patients care close to home. Our hospital system spreads out over a pretty diverse geographical range. So we have a second location already within Columbus, but there's going to be some considerations of probably expanding in the future as well.
Well, great. We definitely look forward to hearing more about this project as it grows. And I assume if some of our listeners and their various institutions want to get more information from you about the clinic in terms of logistics of how you set it up and so forth, I assume you'd be okay if they reach out to you?
I absolutely would. And I'd encourage it. I would say that, I think one of the things we took on in the beginning was making sure we collected a lot of baseline data and then data along the way. And so 5 years in, we have a lot of good, numbers showing that we have decreased cost of care. We've got more patients adhering to anticoagulation and more patients on appropriate therapy. So we're happy to share that if institutions are looking to say, how do we make a business case to get resources for that?
Well, great. Thanks, Andrea, for sharing that information and educating us a little bit as well. And also thanks for serving the state chapter as chair for the last couple of years. We look forward to your future contributions as well.
Thanks a lot.
So Kelly, as a clinical pharmacist, I want to continue the theme of using the entire CV team to help extend and expedite cardiac care. I know I've talked to you before about some of the programs you've worked on at Ohio State to try to extend care as well. I mean, obviously for many years, there's been a pretty critical role for pharmacists in cardiac care, given, the complex pharmacology we use. But I thought I'd just get your input about some new programs that you've been working on that kind of emphasize the role of the clinical pharmacist. Could you just start by kind of describing your current role at OSU and what led you to an interest in cardiac care specifically?
Sure. So I have been at OSU now for a decade. And when I started, we were purely cardiology. So I came on board knowing I was going to do some anti-coag, some antiarrhythmic med monitoring, which is a little bit different than the clinic setup that Andrea's got, and then also sublympic clinic as well. And through the years, I work with a fantastic team of a bunch of pharmacists. We've expanded into a lot of other areas of cardiology. So we have a smoking cessation clinic, a transition of care clinic, a heart failure clinic, really, and it just continues to grow as the cardiologists identify areas where we can help streamline access and education and making sure patients are staying compliant to their meds.
Yeah, I think lipids are one area where, of course, we rely heavily on cardiac medications and especially some new and very evolving set of medicines. So what are some of the things you're doing there in the lipid clinic to help the clinicians extend their care to the patients?
Yeah, so we have 3 physicians that are part of our clinic across the system, and then a total of 8 pharmacists across those clinics as well. So new patients typically come in to see the physician and the pharmacist as a tandem visit, and then follow-up patients, unless they need to see that same physician for cardiology care as well, follow actually with the pharmacist and just see the physician every couple of years, which we're able to do under a collaborative practice that we have set up with the cardiology practice at Ohio State. So it really allows the docs to see more of the new patients and help with that initial plan and goal setting, and then us to help kind of execute that along the way without backlogging their clinic with all the return patients.
How did you kind of set up a collaborative arrangement in which, you're not just providing information, but actually helping assist with the care of the outpatients that you're seeing?
Yeah, so fortunately, I actually came into that setting. So there were a few pharmacists that had started before me and started that process. Actually, I think with our anticoagulation clinic, and got the collaborative practice in place there. So it's kind of just become the expectation when we start new clinics that there will be a collaborative practice in place that allows us to manage to a certain extent. We also have clinical protocols for every clinic that really outline what is within our scope and what's outside of that. And certainly the laws for pharmacists in the state of Ohio, Ohio is actually pretty progressive for the practice of pharmacy. So we do have the fortunate circumstance of being able to do a bit more than our colleagues in other states, where we're able to help a little bit more with some of the ordering and referrals and things like that.
Yeah, that's great. I know you wanted to talk a little bit about smoking cessation as well. That's obviously a tremendous need we have clinically, and we're often understaffed or not really well staffed to provide tobacco counseling to the patients that really need it. So, what areas are you working in there to help address that need?
Yeah, so that was a clinic that I started actually with one of our residents several years ago. And it's something that if other locations, other practice sites are looking to start clinics with pharmacy or that are education driven or have such, specific medication needs, especially if you have pharmacy trainees. Typically, a lot of those trainees are interested in starting clinics and learning how to do that and being involved in that. But it's less of a dollars ask up front to kind of get that off the ground and pilot it and see if it's going to work. So the clinic started that way and it's really expanded since then. It's set up now that practitioners from cardiology, as well as several other disciplines, have their own kind of branch of smoking cessation, can refer patients over, or patients can self-refer through the patient portal or just by calling in to schedule an appointment with us. But really, the goal is we have a lot more time than what our physicians usually have in practice or in clinic to spend digging into the habits of why people are smoking, what their level of dependence is, what they've tried before, what might be good options. And unfortunately, a lot of times coverage is an issue as well. So it's also taking the time to make sure we can get these covered at a cost that's less than what they would spend for a pack of cigarettes to make it an appealing cost option as well to make that quit attempt.
Yeah, that sounds great. Certainly a unmet need. So it's great to have some more resources there. So I know at our institution anyways, so many of the cardiac subspecialties do utilize the pharmacist in different ways. For example, I know in EP here they have a big role with drug monitoring, really doing basically overtaking a lot of the drug monitoring office visits for some of the antiarrhythmics. So do you also, within your overall team, kind of subspecialize in a few of these different areas in terms of each pharmacist? Since it's such a varied area within cardiology where you can be utilized?
Yeah. So antiarrhythmic meds, as I mentioned, is a clinic that I started in when I started at OSU, and it's still one that I staff occasionally. But yeah, exactly as you said, we do a lot of the med monitoring. So especially with sotalol, Tecafin, amiodarone, there's such a prescriptive plan for monitoring that needs to happen. So it's nice that we're able to see the patients, get them in at locations oftentimes a bit closer to them, and also just take care of those and connect them quickly to EP if they need it without the electrophysiologist needing to have those on their schedule. Or even the NPs who are doing now so many more acute things just to alleviate some of the burden off their schedule to get those more routine visits done and then connect patients to those resources as needed.
Well, that's great. I think we'd love to hear more about some of these programs in more detail as we go through some of these topics on future podcasts. And congratulations as the incoming liaison for the Ohio ACC Cardiovascular Team Council. We look forward to your contributions in the next couple of years.
Thanks. I'm going to try my best to live up to the standard that Andrea started.
Yeah. So Andrea, obviously we of course, in our state chapter, we have nurses, we have advanced practice providers, PAs, pharmacists. Do you want to just maybe take a minute and just remind us about the CV Team Council in terms of its makeup and maybe highlight a couple things that you've worked on in the last couple of years and maybe some future goals too?
Yeah, so certainly I think you just, went through and named the majority of our membership: advanced practice providers, nurses, pharmacists, different, whether it can be a cath lab tech or a rad tech. And, really, I think the focus the last several years has been sort of making sure that there's relevant topics to a non-physician member that are always at the forefront. And I think not just within Ohio ACC, but the national ACC as well. I feel like that has been a big focus of this team-based care model, and even more so within the Ohio chapter. I just from your leadership and Gwen and everyone else's leadership, I think we've really felt valued as a team member, and we don't always get that within a big society like this. Some of the things over the past couple of years we've done is held a couple of sessions on different clinical topics where you can share best practices and learn about different topics that you may not be familiar with. We had a session about kind of demystifying how do you maybe create start a research project or put together a case report and then turn that in to either something for publication or a poster to be presented at a regional or local conference. I will make a plug for upcoming. Prior to our fall meeting, we're going to plan to have a CV team happy hour just to get together and kind of meet one another, because it's also just been a really great way to network, not just within your own city, but really across Ohio with different, advanced practice and allied health providers, either within your specialty or within a different specialty, and really kind of open up some of the pathways to, learn and grow from each other. And goals for the future, I have a lot of optimism that Kelly comes with a lot of great clinical and leadership experience already. And so I know she's just going to continue to probably look at some of the things that we've done previously and also bring new ideas into the future with how we can just continue to make this a place to kind of cultivate education and engagement and networking.
Well, that sounds exciting. Just want to thank you both for taking some time to talk about the programs at your institutions and also the council itself. I also want to put in a quick plug myself for our next podcast episode. We got some great insight about the CV team today, and we're actually going to flip to the electrophysiology perspective, and we have a couple outstanding and well-known EP docs from Central Ohio, Ralph Augustini from Ohio State, and Anisha Mean, who's the chief of EP at Ohio Health. And they're going to talk a little bit more about the electrophysiologist perspective for both AFib and some other arrhythmias as well. So hopefully you'll be on the lookout for that next episode. But thank you both for joining in, and hopefully some of our members will be reaching out to you to learn a little bit more about these programs.
Thanks, Kenny. This has been fun.
Yeah, agreed. Thanks so much. And please do feel free to reach out to Andrea or I. If we don't know the answer, we're well positioned to get you connected to somebody who does.
Okay. Well, thanks to our audience as well for joining in this episode of the Cardio How podcast. Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.